University of MacroPro. This is our last webinar for our summer school series, and we're so happy that you're here to join us today. Today we're talking about back injuries. Sorry about that. The WCAB actually tracks back injuries, and so it is a big deal in the workers' comp injury. Today we have a great specialist, Dr. Zhang, who will be with us, and she unfortunately is getting a lot of reverb, so I'm going to make it very quick. I'm going to do some housekeeping and turn it over to her. So today's webinar is worth 1 CEU. You should receive that in about 1 hour. If you don't, please let me know. I have about 30 days in which I can assist you. I have a couple people that'll be assisting later this afternoon. So if you're watching and you need me to do something, please let me know. I'll be happy to take care of that. There is a handout attached to this webinar, so you can go over and download that now so that you have the reference material for in the future. And then if you have any questions, you can put them in the question box. And I'll ask those questions of Doctor at the very end if we have time. And then, of course, you can always watch this and everything else that we've ever recorded on the MacroPro YouTube channel. So, Doctor, I'm going to turn it over to you now.
Okay. Hello, everybody. Thank you for making the time to come to this talk. We're going to talk about the common myths in low back pain diagnosis and treatment. First, a very brief introduction about myself. I'm Dr. Zhang. I'm a double board certified PMR and interventional pain specialist. My clinic is located in the South Sac, 8100 Timberlake, Sacramento, next to the Methodist Hospital and Highway 99. We accept workers' comp, personal injury, commercial insurance, and Medicare patient. I'm also a QME. I've been doing the QME and SIBTFs under Dr. Feinberg's mentorship with forensic medical legal experts. Many of you may know Tracy Faulkner, who is our marketing liaison. This is our learning objectives. So first, let's look at a case. This is a real case that I saw a few weeks ago. A 37-year-old female office assistant retrieved a paper roll from the ground at work and developed acute severe low back pain, unable to get up by herself. She has no prior chronic back pain, otherwise healthy, non-smoker, BMI 29. So after completing the work injury report, she presented to urgent care. What do you think the medical providers should do at the urgent care? I believe most of you read a lot of reports. So what is commonly done at urgent care nowadays that we see? Patient will be seen by a PLMP, physical exam, hopefully, and history, then X-ray of lumbar spine, no fracture. If it's a confirmative answer, then patient get a toradol injection and some sort of muscle relaxant, either Roboxin or Flexeril, and NSAID, either Aleve or Mobic, usually with or without physical therapy, and diagnose lumbar strain and release discharge home. This is not the best approach. So what should actually be done at the first doctor's visit? Number one, we should have detailed physical and history by a provider who is equipped with medical knowledge. So the history should include mechanism of injury. How does this happen? What exactly happened? Patient's characteristics. What is the pain characteristics and associated symptoms? And a detailed physical examination with a few differential diagnoses in mind. For example, let's look at this patient. Mechanism of injury, picking up a toilet paper roll from the ground. That is not heavy lifting. Very likely an educational guess. Patient had a faulty body mechanics at the time. Patient characteristics. 37-year-old woman who most of the physical activity level is light or sedentary. She's an office assistant. Most of her time is sitting in front of computer. She's not big, BMI 29, but looking at her, she has skinny legs and arms. Most of her weight is carried around the trunk and the belly. No previous injury or low back pain. This is her first acute episode. Pain characteristics. Axial back pain majority, predominantly left worse than right, with not very frequent but intermittent radiation to bilateral thigh. In the first week of onset, she did have a few times shooting below the knee. She denied numbness or tingling, and she think her weakness is mainly because of the pain, not true weakness. No bowel bladder incontinence. On the physical exam, patient has intact lower extremity strength, intact cessation to light touch, or all dermatomes in the lower extremity. The lower extremity reflexes were symmetric and within normal limits. However, in the seated slump test, also called seated straight leg raise test, patient reported sharp shooting pain below the knee on the left side, unlike the right side, which is more stretching pain. So based on the above information, the provider who has proper knowledge should already have 3 to 5 differential diagnoses in their mind. Now, in order to come up with a proper differential diagnosis list, it's very important to understand what are the common pain generators in the injured worker for lower back pain. So let's take a brief look. The most common soft tissue, as most of you probably already know, and it's also called lumbar strain. The pain generator is muscle, ligaments, basically some sort of soft tissue. In the chronic phase, it can become myofascial pain. In primary care setting, it's often referred as non-specific low back pain. So this category, the incidence of those can be up to 80 to 85% in injured worker in the especially the first episode of acute low back pain. They normally present with axial low back pain and reduced lumbar spine range of motion without focal neurological findings. Note that I mentioned earlier the straight leg raise test and the slump test is considered as part of neurological exams. In this category with soft tissue injury, the pain normally improves with conservative management within 4 to 6 weeks. The second most common, earlier we talked about muscle and ligament. The second most common is the disc, the intervertebral disc. This category can have disc pain with or without nerve root irritation or impingement. So they may not present with typical radiating pain to the leg or is very infrequent. And this category, which I see most often misdiagnosed and inadequately treated as lumbar strain. Those are the categories like our patient who released from urgent care and just treated with lumbar strain, but her pain is actually come from the disc. And she did have a nerve root irritation, although there's no significant nerve root compression at that stage yet. So other than the muscle, the soft tissue, and the disc, we already alluded a little bit talking about the nerve. So when the disc protruding backwards, they can compress the nerve root that causing the radiculopathy or radiculitis. There are also another common category of nerve structure involvement, which is spinal canal stenosis, and that is more commonly in elderly patients. They may or may not have leg pain. They can present just axial back pain as well. Other than the nerve disc and the soft tissue, there are also joints. So in the back, there's a facet joint. Those are the little joints that just like our hip and knee, they are in our back. They can also become a source of pain. SI joint, famous SI joint can be also a source of pain. And then it's a bone, less often, usually associated more dramatic mechanism of injury, but it can also happen in elderly patient without a dramatic trauma. So those are the compression fractures or sacral fracture. So after the first step, a detailed, thorough physical exam and history, the step two is quick. After you gather those, rule out those who need urgent spine surgical consultation. Those are usually the fractures, the caudal equina syndrome. Caudal equina syndrome is when multiple spinal and sacral nerve roots being compressed in the same time. Patient often presents with bowel or bladder or bowel and bladder incontinence. And those patients, they really have more profound weakness or progressive weakness. The fractures usually they look really sick or they really hurt. And these two categories are most often seen in emergent department, less common in urgent care or ambulatory clinic. So now I want to ask a question. I know it's hard to become very interactive at this point, but feel free to text in the chat box what you think, okay? True or false? Spine MRI makes the diagnosis. True or false? This is almost one of the most common comments I heard from my patients. People think that MRI makes a diagnosis. No, MRI can be clinical significant or may not have any clinical significance if it does not correlate well with the clinical picture, which is your history, your exam. Number two, patient has to wait at least 3 months before getting MRI. True or false? No, this is not true either. Each individual is different. You have to understand the next question. When should an MRI be ordered, right? So whenever nerve or disc involvement are suspected, in my opinion, those are the time you should consider have MRI. If the patient has a strong suspicion that a disc or nerve might be involved, why do you have to wait for 3 months? There's no reason for wait at that case. The sooner the patient get proper treatment, the sooner they get better and return to work. So with other situations, more likely than not, nerve or disc might be involved. The mechanism of injury. Heavy lifting, of course, is possible, but more important is the faulty lifting body mechanics. Like this patient I just described, she all she did was pick up a um, paper roll from floor, and I had a physician friends who pick up a pen from the ground, and here goes his back. So this is not uncommon. How you move really affects whether you engage your core when you do the movement is important. Patient characteristics. The case that we just described, the only thing that I would think put her at a slightly increased the risk is her lifestyle, relatively sedentary. Her her most of her weight is around the trunk and belly. She did not seem to be someone who regularly do strengthening exercises other than the leisure walking. Those ones who are really obese, definitely at high risk of significant disc problem and nerve irritation or nerve compression. The second category is spondylolisthesis. Spondylolisthesis is those ones with slippage. So their vertebral body are not aligned. They are sort of like have the slippage. Those are spondylolisthesis. Smokers, we will talk more why smokers are dangerous. Then the last one is genetics. You choose wrong, right? Someone who come from a family that multiple family members have spine surgery at a young age. I have I have a patient who is 16-year-old, but his back look like someone who is in their 60s. Very unfortunate. I treat his whole family, including his mom. So the next one is the quality of pain. When there is radiating pain, especially below the knee, or there is low extremity, not the back or the buttock, the low extremity tingling or numbness, those are the signs more likely than not there is a nerve component. I put it here, flexion-based pain. So flexion-based pain is very typical, although um, it's not a very specific, but it's very typical for discogenic pain. So those populations, they have difficulty sit. Walking is okay. Walking around actually helps, but they can't sit. This is very typical disc pain, and they tend to got worse when they're leaning forward. They couldn't put their shoes on, they couldn't put their socks on, but they can walk, and leaning backwards actually helps a little bit. Physical exam, like I mentioned, a thorough neurological exam is important, and the positive neurological findings is including the dural irritation sign, which in lumbar spine, straight leg raise, slump test, in cervical spine would be spurting test. Those are the positive findings, even their strength and then sensation and reflex are intact. This is a question for you guys again. I like to get people think because that's how you learn when you think, when you actively engage. So I often heard this. If EMG and nerve conduction study did not find anything, then there's no radiculopathy. Is it true? No, it's not true. Why is not true? Because EMG and nerve conduction study have a lousy sensitivity. They have relatively decent specificity. So because of that, they are not a good screening test or rule-in test. But when they find something positive, for example, the denervation potential, vibration, positive sharp waves, then they are supportive, very supportive of lumbar radiculopathy. So when should you when should you order MRI? When should you order EMG and nerve conduction study? The first situation is when history, physical exam, and the imaging findings are equivocal. So you want something, an extra piece to help you solve the puzzle. The second situation, which is more common, is when patient has coexisting other conditions or conditions may mimic lumbar radiculopathy. For example, someone have diabetic neuropathy. Their bilateral foot and even bilateral lower extremity is already numb up to the mid leg. So it's very hard to tell because you cannot rely on their sensory test. Their motor exam may not be most, and reflex is off as well. So that is the time that EMG and nerve conduction study can pick up both. Okay, so that's EMG and nerve conduction study. So all we were talking about making the right diagnosis, understand what is the pain generator is very important to solve the puzzle, to get patient the proper treatment. And a lot of the urgent care physicians, they do not, or physicians or physician extender like nurse practitioner and physician assistant, they may not be equipped with the proper knowledge to make such a comprehensive diagnosis as I just did. So it's very important to get a patient to see someone who actually knows how to properly diagnose the low back pain as soon as possible, because the treatment for the lumbar spine pain differs based on the diagnosis. The sooner they return to work, the sooner they get treated and they improve, the sooner they will return to work, thus the lower cost. See, this is the common treatment options for low back pain. I specifically put the lifestyle modification or optimization as a bigger font because I really think this is a fundamental for prevent and also treat and maintain for the low back pain management. And we will talk one by one. So this is another question, true or false? Patient has to complete 12 sessions of physical therapy before MRI or injection. Patient has to complete all the conservative treatment before considering MRI or injection. I guess you probably already have a hunch. Neither of them is true. Although insurance will say, yeah, they have to complete 12 session physical therapy before they get MRI or injection. If any of you have had an episode like this, and you probably understand why this is nonsense, because a lot of times when they have acute episode from a disc herniation, they are unable to participate in physical therapy. It's just wasting money to do that. They should get other proper treatment to dial down the pain intensity, allow them to be gradually become more active, so the physical therapy can really kick in to help them at that point. So I list it in this way because this is, theoretically the correct way of treating. You go from the least invasive or gradually dialed up to more invasive treatment or more expensive treatment. This overall, the general direction is right. But remember, we are dealing with people. Each people, their pain generator could be different, their severity could be different, and how they think and coping the pain is different. We really have to individualize our treatment approach to fit each individual. Just like we raise our kids, each kid is different, even they are born from the same parents. We need to adjust our method to help the patient to gradually get better, to build up the confidence, to make that a positive experience for them, so they can, become progressively active and return to work, return to their normal life, feel like themselves again. So this is not always this direction. If something is always, it's wrong. There's no always or never in this world, right? It's just a general rule, but we really have to individualize our approach. So those are the common myths in low back pain. And I think some of them, or I hope some of them, like it's very clear to you that is wrong. First, bed rest is recommended. No, bed rest actually cause deconditioning weakness and cause stiffness. Instead, stay active with low impact movement. Gradually increase the activity level until you can move more. That is preferred approach. Some people say avoid exercise when your back hurts. So very important concept. Pain does not equal tissue injury. Although we do say don't do it when you have sharp, severe pain, but progressive activation and activity modification to facilitate the success of returning to physical activity is the key. The third myth, perfect posture prevents back pain. There are multiple studies have done. It's not just people who do heavy lifting, but the back pain risk is also much higher in people in sedentary lifestyle and light work. Prolonged sitting or prolonged standing or prolonged repetitive heavy lifting, none of them is the best for the lower back. The best way is keeping active, changing positions, and lift with good body mechanics. That's how we prevent back pain and how we, keep a strong core. The last, you probably hear it very often, exercise and physical therapy do not work. I hear this very common from my patients, and those are not patients who just don't want to exercise. They were telling me, yes, the physical therapy get them strong, but they don't, their pain still pretty severe. And this is not uncommon. We have to understand one thing. Number one, the timing of the physical therapy and exercises, right? When patient cannot participate, of course they don't work. They cannot even participate. And also, exercises, especially therapeutic exercises, is an ongoing maintenance treatment. If you stop being active, the benefit would go away. It's like flossing your teeth. If you floss today, you still have to floss tomorrow. Otherwise, you will not be very socially, welcoming. So for majority of patients who really have a muscle strain as the reason of the back pain, the folks should be on conservative treatment. Again, the emphasis is number one, the diagnosis has to be correct, right? In order to know what treatment they need. So for those with muscle strain without nerve or disc involvement, they don't need advanced imaging or surgical consultation or injection or heavy duty pain medication. They really need a progressive activation. And the passive modalities can use be assist to dial down their pain intensity. Therapeutic exercises should be the maintenance therapy, actually should be part of our life. We're going to talk about lifestyle modification. This category, patient education, is the key, which is unfortunately in the current, you know, reimbursement system in healthcare, doctors are not reimbursed for patient education when patient education is one of the most important thing in low back pain. For example, when I mention exercises, the patient that I had a discgenic pain. When you ask, hey, you need to strengthen your core, you don't have a strong core. So patients think core exercises, most of physical therapists teach them what? This type of exercise like crunch, flexion-based exercise. Well, the flexion increase the pressure on the disc and push the disc further posteriorly. Patient actually have increased low back pain. This is not uncommon to hear, like a physical therapy just made the pain worse. The truth is the therapist probably didn't do a perfect job to individualize the treatment for the patient to understand what is the pathology of patient has, or the therapist just didn't get the right diagnosis from the provider who ordered the therapy. So when patient present discgenic pain, patient should really start with extension-based exercises, which some of you may heard McKenzie exercises. That's the traditional name. So patients start with prong, gradually increase more extension-based exercises. While versus someone have a spinal canal stenosis, like my 70-year-old lady whose spinal canal is pretty narrow, or someone who have facet arthropathy, or someone who have slippage, flexion, like a crunch, can temporarily create more space in the canal, so relieve the pressure on the facet joint. So those patient flexion-based exercises actually is more tolerable. So I often tell my elderly patient with spinal stenosis, why don't you start with stationary bike? Leaning forward position, they feel like the back pain is not hurting as bad as they do walking or other exercises. It's a good start for them. And also they feel like success. They start have taste of success with doing exercise. So this is a quick test for you, which one is extension based, which one is flexion based exercises. You can see hollow body, sit up, they are flexion based. They are not best for the disc genic pain or radiculopathy from the disc herniation. The bird dog is extension based, so this might be better tolerated with someone who has disc pain. Plank, when done properly, is a neutral spine exercises suitable for any condition. Is excellent core exercises. Lifting, good lifting mechanics. Don't round your back. Use your leg and your hip, and don't lifting while twisting. Always keep the weight close to your belly button. Use equipment. You ask for assistance. Those are the key lifting mechanics. Next one, I want to talk a little bit about smoking. A lot of people are not aware smoking has something to do with lower back pain. Even once I have a patient who is a nurse, when I said smoking is not good for the back, she was very offended. She said, "What? The low back has anything to do with the smoke?" Yeah, a lot of patients don't know. Smoking increase the risk of low back pain 30 to 50% compared to those who never smokes. And also, the more you smoke, the more likely you have a higher pain score and functional disability. They also reduce healing. As a matter of fact, a lot of surgeons won't operate on smokers because they don't heal. They just have much higher chance of post-surgical complications. Obesity. That's why we counsel patients about weight loss and core strengthening. It's nothing to do with their body imaging. It's really because the more obese, the more likely they get the lumbar slippage, like where I'm showing on the imaging. And the heavier they are, the more severe the slippage would be. So that's the lifestyle. Now I want to talk a little bit about the passive modality of manipulation. I put the category including the chiropractic treatment, the physical modalities, and massage and acupuncture. This category can be used, especially indicated in the early stage of the low back pain for those ones who has muscle strain or when they couldn't participate exercise. But they are not meant for maintenance therapy, unlike exercises. They can provide temporarily, relief, maybe a couple hours, maybe up to a couple days, but they really are not going to be, you know, important to maintain, uh, prevent low back pain. So the only thing that I want to point out here is the second category here, traction. Traction is also called decompression therapy in chiropractic office. This has a little bit more therapeutic property than just passive modality for disc herniations or acute radiculopathy, especially for cervical spine. They do sometimes have utilities. However, mention the cervical spine, I want to very quickly mention that we recommend against the high velocity cervical spine manipulation because of the risk of stroke. Although the risk, although the frequency in incidence is low, but it's a serious complication when stroke occurs. So let's next category we want to talk about medications. Mostly are oral medications with some topical. Topical very safe. They just not, very effective. They provide some benefit. I had one patient who really loved lidocaine cream. He felt that provide the most benefits. By all means, if that's the case, that's very safe medication to use, and I have no issue how many times they use during the day, as long as their skin tolerate. The oral medications, we don't have very good oral pain medications, unfortunately, not because people don't need it. We don't have very good choices. The most effective one is opioid. However, the chronic opioid use inevitably will leads to opioid tolerance. So what are you going to do? Keep increasing the dose until when? So this is a lot of social issue which we won't go into detail, but opioid we try to minimize the use nowadays because of we don't know how to handle the complications when it occurs. And the rest of the medication I want to mention a little bit. Muscle relaxant, that has nothing to do with muscle. They relax your brain. Okay. So they are not meant for a maintenance therapy either. Nerve pain medication, gabapentin, Lyrica are the number one first line choice. The problem with these two medication is often even before the dose is reached to the therapeutic dose, patient already have difficulty tolerating their side effect. Often some people say it makes me feel zombie. Some people feel like they forgetting things. So that is unfortunately not uncommon. but this is probably most widely prescribed nerve pain medication with a relatively better side effect profile than many other medications. Next one, I want to talk about interventional pain procedures. This is what I've been asked the most by my friends in like my friends who are claim adjusters and my attorney friends, because people say those words all the time, but nobody ever had a chance to really explain what they are, how effectively they are, and what they should be used for, and how safe they are. So, because of time reason, we're going to mostly talk about the most common procedures that you see in daily basis, which is epidural, facet treatment like medial branch blocks, radio frequency ablations, and SI joint. So remember earlier I talked about the importance of nail down the right pain generator and or the diagnosis, because different pain generator, the interventional pain procedures, there are different interventional pain procedures for each category. If your pain is from the nerve root irritation or nerve root compression, which is radiculopathy or radiculitis, or spinal canal stenosis with or without nerve root involvement, or the disc pain, disc herniation, disc bulging with or without radiculopathy, the treatment choice in interventional pain is epidural steroid injection. There are three ways of doing epidural steroid injection: interlaminar, transforaminal, chordal, and we're going to talk one by one. So this is another question for you: true or false? Okay, patient has to have an MRI before spine injections. Is it true? Depends. It's partially true. Okay, if the patient, this is my approach. If patient is scheduled to have epidural steroid injection, yes, I need to see the MRI. This is good practice to say what the structure look like, not only where to put, but also what to avoid. You have to know the patient anatomy before you put down the needle into the epidural space. But if you suspect patient pain is mainly from the joint, like facet or SI, then MRI is not strongly indicated. You don't have to have MRI if your suspicion, like very like most likely or probably the number one pain generator is the facet or SI. You can directly go for injection with just an X-ray. Again, consistent with what we mentioned earlier, the MRI is indicated when nerve or disc involvement is suspected. This is just a brief slice to help you orient yourself in terms of the structure. The disc is between the vertebral bodies. These two are the joint of the facet, and this is lamina because we're going to mention it later on. So the interlaminar, I put a hyphen, so just help you to understand. Interlaminar is you put the needle through between the laminar space to reach the posterior dorsal epidural space where the dorsal epidural fat is most abundant. Okay, the transforaminal approach is put the needle through the neural foramen into the epidural space. Each procedure has its own advantages and disadvantages. For transforaminal epidural steroid injection, you deliver the steroid and anesthetic directly next to the disc. So this is my own patients. You can see the needle put through the neural foramen reach the epidural space, and with contrast, it shows that the medication goes right behind the disc, next to the disc, and also the nerve root comes out from here. You can see the contrast also tracing the nerve root. So when there is nerve root irritation and disc pain, this is treatment of choice. It can also work for spinal canal stenosis. And this is just showing a disc herniation where the disc would be on the MRI, spinal canal stenosis. So with interlaminar epidural steroid injection, you put the needle through the lamina, between the lamina space, and you put the steroid and numbing medication in the dorsal epidural space. You can see from the contrast pattern. The advantage of this one is it works for some patient. It's better for the spinal canal stenosis. It also can give a larger volume, so it can cover multiple segments. The third approach is chordal epidural steroid injection, which is less commonly used. You put the medication through the end of the epidural space, which is hiatus. The advantage for it is if you have extensive lower lumbar spine surgeries in the past, hardware here, altered anatomy, it's still safe to put it in through the hiatus. The disadvantages is a lot of medications may escape from the sacral frame like this showing here. So how effective they are? According to one of the society guideline review of 13 high quality random controlled trial, the interlaminar epidural steroid injection has level 1 evidence for disc herniation, level 2 evidence for spinal stenosis and discogenic pain without radiculopathy. Another 2 studies put the random controlled study, and it shows that transforaminal approach tends to be more effective than interlaminar approach and has more immediate short-term better pain control. So now let's talk about when the pain generator is the facet joint. So the facet joint, just like a knee or hip, can come from degenerative changes. It can also have, asymptomatic degenerative changes, but the pain boom triggered by some sort of trauma. This is normal facet joint space well maintained. This is progressively getting worse. You see the joint space become less, and then with osteophytes as well. So for the facet mediated pain, then the treatment choice nowadays is 2 diagnostic medial branch blocks followed by radiofrequency ablation for the medial branch nerve if both diagnostic medial branch blocks give us positive response. So what that mean? So this is a facet joint. So they are innervated by a small nerve branch from the spinal nerve, the dorsal branch, okay? And you can see from the other diagram, each joint has 2 little medial branch nerve innervate, one from above, one from below. So in order to treat this one joint, we need to put down 2 needles. And this is also of one of my own patient. So we are putting 3 needles to treat L4, L5, and L5S1 facet joint to diagnose facet mediated pain. So we put no more than 0.5 cc of numbing medication and ask patient to move afterwards and say in the corresponding duration of the numbing medication, does patient have 80% or 70% more pain relief? If it is, it's a positive response. But why do I have to do 2? Because one positive medial branch block response can carry up to 37% of false positive. But when you do 2 diagnostic block, both give you consistent response, then more than 80% of likelihood the pain is from the joint that you blocked. So if you had if you had a positive response to dual medial branch blocks, then we move into the treatment, which is radiofrequency ablation. Some surgeons like to say neurotomy or rhizotomy. That's all refer the same thing. Basically, is thermal ablation of the medial branch of the joint. In this case, we line the needle tip along the nerve course and we connect the needle to a radiofrequency generator who generate the heat the needle tip up to 80 to 90%, and we burn that nerve. So you say, okay, the nerve is burned. You can have pain free forever. Now, if we look at the picture earlier, we are burning this terminal branch, but the motherhood of the nerve are still there, are still intact, which we don't want to ablate. We want to minimize any damage of motor function. We just want to destroy that sensory nerve branch if possible. So the little branch, they can still grow back, but if they grow back very slowly, on average takes 6 months to 12 months to grow back. That's why people say you may have to repeat 12 months, 6 to 12 months. However, each individual is different. My observation doing this for 10 years, majority of my patients come back to repeat 10 to 12 months. This is radiofrequency ablation, just showing how it's done. This is a more precise, longer duration procedure because you have to line up the needle tip precisely along with the nerve, the course of the nerve to get the uh, best outcome. So how effective they are. According to this year's systematic review of 17 random controlled trial, level 2 evidence, both short-term and long-term improvement, which is pretty amazing in the world of pain medicine. Intra-articular facet joint used to be done long time ago when there was so many evidence showing MBB does a better job, but they still have its utility in my view if you have rheumatoid arthritis or very obese patient, usually they have more grinding of the joint. If they don't get good relief with MBB, maybe you should look at the MRI again. If the MRI shows in the T2 sequence that there is a lot of fluid, there is a lot of fluid in the facet joint. So maybe this case would be a good candidate to actually aspirate the joint effusion and put a steroid to dry the joint. So just by reduction of the joint capsule extension can reduce the pain. SI joint pain. So SI joint pain, there are two kinds. One is its own joint, sacroiliitis. The other one, which in my opinion is more common, is extra-articular pain. Look at how many ligaments it has in the SI joint. So it's more common a biomechanical issue than the actually joint arthritis. The risk factors are obesity, rheumatoid condition, leg length discrepancy, whether it's true or apparent, such as scoliosis, any gait abnormality that doesn't give you balanced gait. So we see a lot in those one with a stroke. After stroke, they just have hemiparesis one side. Persistent strain or low grade trauma like jogging. Some long distance runner also have a little bit more common SI pain. And pregnancy, your ligament get looser. I had it when I was pregnant with my son. People who have fusion surgeries in the lower segments. So with the fusion surgery, the level above the fusion, the level below the fusion tends to got more joint mobility because you artificially fuse the segment. Diagnosis of SI is difficult. There's no single history of physical examination sign, and those are the ones give you a little bit hint, which I will leave for you to read by yourself, just for the time reason. Um, the diagnosis of SI dysfunction nowadays, the golden standard is fluoroscopic guided diagnostic SI injection with just local anesthetics without steroid. It has its limitation, but we don't have better ways to do currently. For the treatment, you can add a steroid. This is also one of my patients. You put the needle in the joint, you put the contrast, you see the contrast line up with the joint nicely, and also sketching the outside of the joint. The true treatment, we used to do the ablation just as we did for the facet. We ablate for SI. Those are the nerve innervate SI. We use a palliative method to do ablation. I don't know if it's still approved in the workers' comp world, but it has, Medicare has not reimbursed this procedure probably in the last 1 or 2 years. So in the society, performing this is dramatically dropped because of reimbursement issues. And SI can also do SI fusion, which we will talk about a little bit more if we have time. So there is a common myth that injections are not safe and need to be repeated every 3 months. I hope by this stage to here you already understand this is not true. Injections is actually much safer than you get hit by a car when you walk in the street. If it's done properly by competent specialists who had proper training and careful planning, and the effective duration really varies greatly from person to person, depends on the pathology, the anatomy, a lot of other factors. And a lot of people said, oh, injections not working. Number one, the first question is, what's the diagnosis? Not epidural won't work for the facet pain. Facet injection won't work for the discogenic pain, right? So you really have to nail down the correct diagnosis in order to treat patient properly. So we have 5 minutes. I will go a little bit faster. So the next one I want to very briefly touch on the minimum invasive spine procedures, specifically the percutaneous ones that the pain physicians normally do, not the surgeon do. For example, the spinal cord stimulator for the post-laminectomy syndrome or failed back syndrome, vertebral compression fracture kyphoplasty, same thing, sacral fracture, sacroplasty. Vertebrogenic back pain, which is the modic changes of the vertebral body. So the vertebral end plate changes, that's the basal vertebral nerve ablation. SI, we mentioned, because RFA is not getting reimbursement very well in the last 1 or 2 years, every company is having a booth at the pain conferences for SI fusion, because SI fusion is reimbursed well. Very sad, is guided by reimbursement, not guided by medical decision, isn't it? This is called mild. Some of you might heard. This is for spinal canal stenosis, especially when you say thick ligamentum hypertrophy. I actually like this procedure. Some people don't want to have a major surgery, but they see a lot of thickened ligament, and you can use this little device, do it under fluoro, and the patient can walk back home. Patient doesn't have any hardware in their back, and the infection risk is very low. I like it. A lot of my patients, especially late 70s, 80s, they don't want to do surgery. And if they have qualification of this might not be a bad choice. So now we have talked about the last myth I want to mention. This one is surgery is the only cure of the chronic back pain. This is not true, because surgery fixes the structure, but the structure does not guarantee pain relief or cure. For example, 15% of people still have persistent pain after discectomy, although there is no disc visibly impinging on the repeated post-operative MRI. And the revision surgery in the same level, reopening 6%, that was pulled from 21,000 patients. Recurrent low back pain was up to 25% at 2 years. Adjacent segment disease after fusion, that's very well known. Adjacent stenosis, or just like adjacent arthritis, adjacent level of SI problem. This is also predicted prevalence up to 36%. So some people, especially younger population, some of them will hurry into surgery. I want to tell them back surgery is not knee replacement or hip replacement. Back is much more complicated. Here you go. You have all my common myths. This is a summary slides, and you have my references. Now I'm ready to take any questions.
All right, doctor, I don't see any questions at this time. I did have somebody say that they do need you to work with them at their clinic, which you did an excellent job, as we totally suspected. Okay, let's see. Do you think that interspection procedures is worth it?
What procedure do you mind?
Intercept procedure?
Oh, intercept procedure. That's the BVAN. Uh, Again, the patient selection. If the patient's pain is truly vertebrogenic, it can be useful, but it has to be very selected in the patient population that if the pain is truly from there. It's normally not my first line to go to because it's more invasive. If among the interventional procedures, I will try other less low risk procedures to make sure that all the other things fail, or it's probably very confirmed that is the vertebrogenic pain before I conduct intercept.
All right, let's see here. I think that was the last one, but I do want to share with you that we did get quite a few comments that said that this is very informative. It was an amazing webinar. Thank you so very much. Very informative presentation. So we have people asking, thank you. I had an injured worker who wanted, let me see if I can open this up so we can read it all the way. I had an injured worker who wanted to do one very early on, looking at the whole picture. So I'm not too sure which one. It must be the surgery they wanted to do early on. But it wasn't really a question. I think it was just a statement from Melissa.
Yeah, I don't fully understand. Is it asking that patient wanted to jump into surgery? Is that the question?
And there's no actual question. It was just a comment that she made. So, and I don't see that she's added anything to that. So, with that, we're going to wrap this up. We thank you all for joining us. And Doctor, thank you for the great information. As you can see by the responses, that people were definitely engaged with your questions and answers, as well as believing that your information was very helpful. So thank you for being with us and for making our programs here at the University of MacroPro just so professional. So until the next time, everyone, we want to wish you good health, good wealth, and a wonderful summer. So we will talk to you later. Thank you again, Doctor. Bye-bye now.
Thank you very much for this wonderful opportunity. I do have my contact information on the second slide. So if you have any questions, feel free to reach out to me.
Yes, and hopefully they downloaded those off of the webinar control panel. So we'll give them just a second to do that. Oh, you're getting lots of applauses and thumbs up. So that's great. Thank you all very much. And also, if you have any ideas of what you'd like to see in the future, please put that into the comment box or email me at Diann, DIANN, at macropro.com. And we will be happy to research that for you and see if we could do it. Yesterday, we had a presentation and part of it talked about sexual dysfunction. And the person said, we need an entire webinar on that because it's, so many different injuries can cause this. And I'm like, okay, let's look into that. So we listen to what you say and we're happy to customize it. All right, everyone. Thanks again very much for joining us, and we will talk to you the next time. Bye-bye now. Thanks again,
Thank you.
Doctor.
Thank you, everyone, and thank you, MacPro, for this opportunity.